Next is Dr. Ashwini Joshi from Pune. You have co-authors by Dr. Amit Rajput and Varsha Jagtap, right? So Ashwini, introduce yourself in one line.
Good morning, everyone. Good morning, judges, my teachers, colleagues, and dear friends. I'm Dr. Ashwini Joshi. I'm a consultant physician and diabetologist at Dinanath Mangeshkar Hospital, Pune. I'm going to present a case of recurrent hypoglycemia. It's a team effort of 3 doctors with Dr. Amit Rajput from Jalgaon as well as Dr. Varsha Jagtap, who is an endocrinologist with our hospital. So brief case history of this interesting case of hypoglycemia. A 56-year-old woman residing at Jalgaon. She presented to the clinic with 6 weeks history of recurrent neuroglycopenic symptoms, and they improved after food intake. There was no history of diabetes, thyroid disease, any connective tissue disease. She was a non-addict. Her family history was negative for any kind of endocrine disorder. She was on tablet telmisartan 20 milligrams once daily for hypertension since 1.5 years. Tablet aspirin 75 milligrams with atorvastatin 10 milligrams since 2016 during a hospitalization at a private hospital for similar symptoms in 2016. When she was seen, she had a height, she was having a 155 centimeter height, 65.4 kg weight, and BMI was 27.2 kg per meter square, and systemic examination was within normal limits. She was evaluated at Jalgaon and was detected to have severe hypoglycemia, and her AGP flash continuous glucose monitoring was done. Now this is a 14-day AGP which is done, and it shows episodes of severe hypoglycemia during most of the time during the day with peaks postprandially only. She was seen by one endocrinologist there and was advised a 72 hours fast under observation, and these are the readings obtained during that fasting state.
She was surprisingly
Stable during this phase. She did not have, she didn't become unconscious or anything. She was under monitoring.
What was the sugar value?
Yeah.
It was 40 milligrams.
So BSL fasting then was 44.
No, this is the AGP.
Yeah.
But were you monitoring on glucometer also during this period?
Yes, yes,
What
sir.
were the glucometer values? Were they matching with the AGP values?
Yeah, around 40, 45.
But asymptomatic.
Occasionally she had symptoms. At home she had symptoms.
She was fasting for 72 hours.
Yeah, but the endocrinologist said surprisingly she didn't. And he did for Whipplestat.
And you look for simultaneous insulin level?
Yes. During that phase, this is done at Jalgaon, where the BSL fasting was 44 and simultaneous insulin fasting was 195 microunits per ml with the upper cutoff of 15. So with these readings, she was referred to our hospital for further evaluation at Pune. So when she came to me, that was the admission at Dinanath Mangeshkar Hospital. She also, by that time, was put on oral voglibose by Dr. Amit Rajput there, hoping maybe her postprandial hyperglycemia which is happening, and then there is severe hypoglycemia, just to cut down that carbohydrate load, thinking that he had put her on voglibose. And then this was the AGP which was done with us, which again showed a similar kind of a pattern. When she was referred to me, I was almost, like we both were discussing, we were almost sure she is going to turn out to be insulinoma. So we started working her up on those lines. So with me, but her fasting was 77, PP sugar was 195, and her insulin fasting and PP were in thousands, more than 2,000 fasting, and beyond 4,500 was her PP simultaneous insulin with C-peptide levels as 3.67, which is almost normal, and C-peptide PP is 5.58. We did as insulin as to C-peptide ratio, and it was normally should be less than 1, but it was beyond 1, way beyond 1. I'll explain why it happened. By the time these reports were getting ready, we were trying to hunt for insulinoma. So we did a CT abdomen. It showed an ill-defined early arterial phase enhancing lesion along the medial wall of second part of duodenum. That was the CT report. So we did one endoscopic ultrasound by a very well-known gastroenterologist, and he called me saying, "Madam, there is no evidence of any pancreatic lesion." But still with these values, we thought, let's go ahead with a DOTA PET gallium scan, and there was no abnormal somatostatin avid lesion noted to suggest any neoplastic etiology. But incidentally, they did report a right axillary lymph node showing somatostatin receptor overexpression. Now we were in a catch situation whether to biopsy this or not. Looking at the literature, extra abdominal presentation of pancreatic insulinomas is almost not seen. So with this type of insulin and C-peptide ratios, we decided to go ahead, and then we went back to our books and tried to follow this flow chart. Now we had a documented hypoglycemia without a patient who did not have diabetes. She was of course apparently healthy. Her fasting glucose level was less than 55, and she had increased insulin and a Whipple's triad as well. Now we had one C-peptide value which was above the normal limit, so we decided to follow this. We had almost these three causes, out of which insulinoma, sulfonylurea are the sulfonylurea consumption. That history we had ruled out by repeatedly asking the relatives, and there was nobody diabetic in the family. So factitious hypoglycemia was practically ruled out. And then insulinoma, I was not able to find any good lesion. So then the remaining cause was autoimmune. Hence we decided to go ahead sending insulin antibodies. Of course, we had done simultaneous other testing like cortisol, the ANA and RA levels were also negative. Her HbA1c was 6.3, we'll explain why it was, and her insulin antibody level came out to be 54, and negative is less than 10, positive more than 10. Okay. So our diagnosis was endogenous hyperinsulinemic hypoglycemia due to insulin autoimmune syndrome or Hirata's disease.
Why it is not insulin receptor antibodies?
Generally, the lab
If you are
test.
doing an autoimmune, there could be an insulin antibodies or it could be insulin receptor antibodies, and there also you can differentiate.
The lab gave me insulin antibody levels. So we have to check for pattern of insulin C-peptide and insulin as to C-peptide molar ratio to differentiate between the etiologies of hypoglycemia. Normally there is equimolar secretion of insulin and C-peptide in the portal circulation. Insulin is destroyed by the liver within 4 to 5 minutes, and C-peptide is removed from the kidneys within say 30 minutes. So normally insulin to C-peptide ratio is less than 1. Now if we have a very high level of insulin and a very high level of C-peptide and insulin level in thousands with a ratio more than 1, there are only two reasons for this. One is either, autoimmune syndrome or exogenous insulin administration where C-peptide will be suppressed. So presence of insulin antibodies tells us that it is insulin autoimmune syndrome, and in insulinoma there is a simultaneous rise and the ratio is less than 1, and one is able to localize insulinoma on imaging. So insulin autoimmune syndrome or autoimmune hyperinsulinemia or Hirata's disease is an important cause of severe hypoglycemia. The insulin antibodies that are formed have a typical high binding capacity and low affinity, meaning whenever there is a glucose load or a meal which is consumed by the patient, then there is a postprandial rise in the blood glucose level which stimulates insulin secretion. That is a normal response. These antibodies being high, they have a high binding capacity, so they bind this insulin, and then insulin is not available for the blood glucose to go down. But eventually what happens is these antibodies have a low affinity, so they dissociate rapidly as well from this insulin which is bound, and there is a severe hypoglycemia that happens especially postprandially in these patients. The clue is unusually raised insulin and only moderately raised C-peptide levels with a concurrent insulin to C-peptide ratio more than 1 is suggestive of IAS, and misdiagnosis as insulinoma may lead to deleterious effects on patient. Hence, IAS needs consideration during workup for hypoglycemia. The lady was treated with small frequent meals. She also received oral alpha glucosidase inhibitor to reduce the carbohydrate burden, and that was already started by Dr. Amit. So even then she was hypoglycemic, so we put her on oral prednisolone 1 milligram per kg, and she came to a follow-up after 3 weeks. So after 3 weeks when we called her, we can clearly see that the episodes of hypoglycemia have started to reduce significantly as compared to her previous admissions. We have a comparative CGM here, where this is at presentation at Jalgaon, where she stayed in hypoglycemia. This is after alpha glucosidase inhibitor, and this is after oral steroid administration. Her recent follow-up tells us that she is comfortable, did not have a single episode of hypoglycemia at home, and her latest blood sugar fasting stays at 104 and postprandial at 130. So that is...
So what was the lymph node and the growth hormone activity there?
I did not biopsy the lymph node.
So when you are saying, there is a lymph node and there was some somatostatin activity in that, why didn't you think of paraneoplastic hypoglycemia?
Sorry,
So
why
there-
did you think? I didn't get your question.
And there, the paraneoplastic production of growth hormone or IGF-1 or IGF-2 can cause hypoglycemia, which is again something which will present very similar to this, will be responding to steroid or removal of the tumor. So this is one case, where you didn't find anything in pancreas, fine. You had small lesion close to second part of duodenum, and you have an axillary lymph node, and you have some, PET CT suggestive of somatostatin activity. I think it is very important to do IGF-1 level and look for paraneoplastic cause.
Okay.
Paraneoplastic overproduction of insulin or IGF-1 will lead to very similar, symptom.
At least an
And you must,
FNSC
I think
could
you
have
must remove
sorted
the...
out, yeah.
Actually, I did call the oncosurgeon to look for that node and let us biopsy. It was our plan.
Yeah.
Meanwhile, we did receive these antibody levels, which
No,
were
that's
high.
fine. That's
so
fine.
true.
That is
so
fine.
we stopped at that
But
time.
if it is paraneoplastic, then you are still missing it. So
It
at
could
least
have been a
IGF-1
lymphoma.
level has to be done.
It could be even lymphoma.
Yeah.
NHL
So
presents
if you are
like
getting a lymph node
paraneoplastic
with,
symptoms of hypoglycemia.
We did not biopsy because it was not clinically palpable. Yes, the surgeon also did not agree with the
But
lesion,
this
but
is
the scan did show overexpression in
So
that
that's
area.
what I'm saying. So this may indicate presence of paraneoplastic hypoglycemia also. No, C-peptide has gone up. And the insulin level is significantly high. But we have not looked at IGF-1 activity.
No.
It's not extremely high. Agree.
So we have to keep in mind paraneoplastic hyperglycemia in such patients and look for IGF-1 activity.
Okay.
And, put all the efforts to locate a lesion and maybe do a biopsy in this patient.
That was
Okay,
actually
because
mandatory.
she's following with us, so we will definitely
Look up for this also.
look up for that.
And also
yes.
look for thyroid function test.
It was done, sir. Thyroid function normal. We did a workup for collagen vascular diseases, connective tissue diseases. That was negative. We did this thing also, protein electrophoresis to rule out any myeloma-like disorders. That was negative. But with this insulin antibody level coming very high and the pattern fitting into that, so we stopped at doing that
And there are
biopsy.
many
See,
drugs.
everything fits in there if you had excluded paraneoplastic. That has to be excluded.
Okay.
And you should also look for the drug screen. Many drugs also can produce
Yes,
antibodies.
yes. There are drugs
Many
like
drugs.
she was not on like carbimazole or
Because,
rifampicin.
I presented a
these
same
are the,
patient
yes.
of Hirata disease because Hirata was the first time from Japan in
Yes.
1970.
Yes, 1970.
Presented about 100 patients of Hirata disease. And what he says was that you rule out all the conditions.
Yes.
And then you, of course, demonstrate antibodies. Now, if steroid therapy should show that the antibodies are going down, then maybe you're right. But I think I agree with them. They need to biopsy that lymph node.
Okay.
That is something which is very important and very uncommon cause, but it does happen, and we have seen patients with that. So paraneoplastic, whenever you are looking for hypoglycemia and the cause is not obvious and you were suspecting insulinoma, you didn't get insulinoma, look for paraneoplastic cause. That
So
has
many,
to be
so many neoplasms.
and IGF-1 levels must be done.
Okay.
Mesenchymal tumors, so many, even lymphomas, atypical lymphomas, NHLs, everything may be because of a NHL lymph node itself. And they respond to steroid in the beginning.
We have, seen, we have in fact reported one case with prostate also, which is very uncommon cause for paraneoplasty.
Okay, definitely we would consider those and give a feedback regarding what happened next.
Good, good. Anybody has any
Good,
questions?
good.